We'll go ahead to the next slide, please. Thank you for attending today. On behalf of National Hemophilia Foundation, welcome to Adult Men's Track, Stop Suffering, Pain Management Approaches for Adult Men. My name is Erica Bailey, Manager of Education at the National Hemophilia Foundation. For privacy purposes, prior to joining our meeting, we do hope you were able to rename yourself with your first name and category as a participant today. We'll go ahead to the next slide, please. We did have a couple of reminders before we got started. Please use the chat box to write any questions or comments you have. Our speaker will try to respond to your questions during the end of our session, during our Q&A portion. Please make sure to give additional feedback by filling out our evaluation form that will be emailed out to you tomorrow. And this presentation will be recorded and available to watch online. Next slide, please. And our speaker today, Dr. Kim Maurer, for this session has no disclosures. And I would like to introduce our speaker today, Dr. Kim Maurer, Oregon Health and Science University is where she is representing today. Dr. Kim Maurer.
Thank you very much, Erica. Thank you all for having me. I'm a pain management physician and anesthesiologist here at Oregon Health and Science University, otherwise known as OHSU, for any of you who have been to Portland, Oregon. We call it that for short. And we're going to talk a little bit about pain and hemophilia. We're going to go over some of the new advances in pain, a few of the things that we can do to manage pain specific to hemophilia, and some things on the horizons. The first slide we're going to do is going to talk a little bit about the finances of pain. So if you look at these numbers, you're probably wondering kind of what they all apply to. Well, they all have very different meanings, and we're going to kind of go over them just to kind of point out how big of a problem pain is. Now, these numbers aren't specific to hemophilic arthropathy or hemophilia pain specifically, but specific to general pain and mostly chronic pain. And if you look at the top number, the $380 billion, that's the amount from the year 2019 to 2020 that was spent around the United States and world, and the entire world actually, for chronic pain management and outpatient pain management centers. And the reason I highlighted the 380 billion is I wanted to show you how much larger it is than the two numbers below it, the 112 billion and the 89.3 billion. And the interesting part about this is the 112 billion is the number spent on outpatient care for diabetes. So that's the number we spent around the world on outpatient diabetic care. This doesn't include all the things that happen in a hospital for diabetes, but outpatient. And the 89.3 billion is the number of dollars we spent in congestive heart failure around the world from the year 2019-2020. And so this highlights how big of a problem pain management is and how much it consumes in the world, and that it's almost 3 times the amount for diabetes and even more than 3 times the amount for congestive heart failure. Of course, these numbers aren't perfect, but it just gives you a little ballpark. Now, I want to go through a little bit of the background of the physiology of pain transmission. And if any of you have heard me speak at other men's track lectures, I hope this isn't too much of a repeat. But we're going to go over a little bit about how pain is processed to help us understand why do we get chronic pain and how does this happen at the cellular levels in our body. So the first thing is reception. And as I talk about each area, I'm going to highlight it on the little slide there on your screen with a different color. And reception is down there in the blue-gray color, highlighting your pain receptors and your spinal nerves. So down below your skin at the surface area, we have all kinds of receptors. We have thermoreceptors, we have chemoreceptors, we have touch receptors, we have prostaglandin receptors. We have all these receptors that are able to sense stimuli from the outside environment. So we call the first session of pain kind of our reception stage. And that's where the pain signal is recognized at the body. And this happens in the periphery in our skin receptors. And then we have what's called transmission. And it goes up through these receptors, through our various peripheral nerves to start to get close to our spinal cord. And before it goes all the way into the spinal cord, it reaches the dorsal horn. And if you look at that little cartoon, the dorsal horn is almost like a little lily pad or out pocketing or like a little electrode there sitting outside the spinal cord. That's like a small Grand Central Station in New York City that's kind of sending all the signals to the spinal cord. And so these nerve transmission pathways, or this electrical current from these nerves, comes up from the peripheral nerves through to the dorsal horn. And the dorsal horn is like Grand Central Station, and it decides where in the spinal cord it's going to send its next train. And then we have modulation. Modulation is here in green. Modulation is where a lot of the receptor signaling that's come from those peripheral receptors gets amplified. So this is where your dorsal horn, which is a part of your spinal cord, can say, wow, Kim, you just touched a hot stove and this is really, really bad. And your finger is really, really going to hurt. And I'm going to make this a really strong signal that goes up to your brain. Or my dorsal horn might say, Kim, you touched the stove and it's kind of bad, but there's a mountain lion chasing you down this mountain right now. So I need you to focus on running. So I'm not going to send such a strong signal to your brain to make that finger hurt from touching the stove. And that's where my dorsal horn on my spinal cord wouldn't amplify the signal. And we're spending a lot of research right now in the dorsal horn to try to figure out why certain people's bodies amplify signals and some people's bodies don't amplify the same signal that someone else's body may amplify. And then our next color here is transmission. Transmission is kind of that baby bluish color that's going up, bluish gray. And this is where the signal, if it's been amplified or not, in the spinal cord is now going up to your brain. It's heading towards the brainstem and it's going up through the spinal cord pathways. And it's traveling from wherever it came in, your mid back, your low back, your neck, going up to the brain. We don't really know a lot about what happens in transmission. And then as we go next from transmission, we go to the pink area, and this is our processing and prioritizing. And this is where we give meaning to our pain. This is where the brain sees the signal and says, oh, the mountain lion is coming. Please keep running. Do not pay attention to your finger. Or this is where my brain says, oh my gosh, this is going to be such an overwhelming thing that you're not going to be able to sit still or eat or focus on driving home from work, Kim, because your finger is going to really take precedence over everything else you're sensory stimulating and noticing today. And then we have a second area of processing and prioritizing, and this is our somatosensory cortex. And this is where our brain assigns that meaning to where it's going to hurt. So this is where the brain says, okay, we know this is going to be a heavy, really, really, really in-depth signal, and we want Kim's pinky toe to feel the pain. And so this is where the brain decides that the pinky toe is going to hurt. And then descending inhibition. This is the gray column coming down, where now the brain has decided what it wants to do with this pain signal. So now it has to take all this electrical current, send it back down through the spinal cord to the big toe so that my big toe hurts. And that's kind of how it's all processed. And understanding that helps you break up a pain signal to really see that pain is a pathway. It is not just as simple as touching a stove and pulling your finger off the hot stove. There's a whole process that happens around it. And as scientists learn to dissect each process, we're better understanding where we can modulate that electrical signal to help control pain. Now, some important concepts when we look into pain is number one, is pain is physiology that's gone awry. It is that system that's not working normal, and that's why we feel pain. Some of pain is normal. It's a defense mechanism to say, the mountain lion bit off my foot. I better get away from this mountain lion. Not good for me. But some of it is just our system gone awry to get on autopilot and keep hurting, even though we know at a cellular level, your body's okay. And the important thing to remember about pain is that most of the time when you have pain, it's not going to lead to ongoing pain. Sometimes it will. Sometimes it definitely will become chronic. But in most cases, for most human bodies, nerve damage or pain that happens doesn't lead to ongoing pain. And I kind of put in a good example of diabetes on this slide, because diabetes is that classical disease concept where some people get painful diabetic neuropathy and some people get non-painful diabetic neuropathy. And we also know, just like in diabetes neuropathy, that the severity of what's happening in your joint that may be bleeding from your hemophilia or may not be bleeding from your hemophilia does not always correlate with your severity of pain. So you can have a very good looking joint with just one bleed over a course of a lifetime, and it can hurt pretty badly. Or you can have a joint that's bled and bled and bled into itself, but it doesn't have much pain. And that's true pathology, and that's truly how the body's physiologic system works. And we, to this day, still do not understand in pain thoroughly why that happens, why the severity of the damage doesn't always correlate to the pain. And the hard part about pain management as a provider treating it, which is what I do, or as a patient, if you experience it, and sometimes providers are also patients and patients are also providers, is that we have no objective test to really show how bad pain is. It is really all subjective. My 3 out of 10 could be Mr. Smith's 1 out of 10, could be Miss Smith's 2 out of 10. When you go to a cardiologist, they can put a blood pressure cuff on your arm and take your blood pressure and say, Kim, your blood pressure is 120/80. And we can all agree on that because we have this hard, finite number in front of us. But when it comes to pain management, we don't have that. We have one person's 1 out of 10, one person's 9 out of 10, one person's 7 out of 10. It's a very individual, subjective process, and it makes it hard to treat because no provider really understands what their patient's going through. And that makes it hard to know how your patient's feeling. And the other thing about pain that's really, really interesting, and it happens really kind of uniquely to pain and not to too many other conditions, is that our entire nervous system gets involved. When you have pain of that toe because I stepped on a nail or because the mountain lion tried to bite it off, my whole nervous system can get inflamed, even though the injury happened down in that little toe. My brainstem is involved, my spinal cord's involved, my dorsal horn's involved, my peripheral receptors are involved, and your whole system gets really inflamed. And chronic pain is actually kind of living in a state of chronic inflammation. And that's why we went through that little schematic to look at how the whole system gets involved when that little toe gets stepped on or you step on a nail with that little toe. And then the other whole part of pain that makes it challenging is it can change everything in your life. It's not just the sensation of what bothers you, but it's the fact that now when your little toe is hurting, you're kind of cranky because this toe hurts all the time. And then you can't walk. And if you can't walk, you can't go to the mall with your family. And if you can't go to the mall with your family because you can't walk, you become depressed because you're sitting at home alone while they're out at the mall. And then if you're not out walking and going to the mall, you're not gaining exercise. And if you're not gaining exercise, you might start gaining weight. And then if you start gaining weight, your diabetes gets worse. Or then if you start sitting around, your joints start hurting because you're not as active. So it becomes this whole process where if we didn't have the darn toe hurting in the first place, we wouldn't get down this cycle down the road. And that's why we really work on preventing chronic pain, because we know all of these things that happen down the road. Now, it's a multimodal puzzle. A long time ago, we had this really fancy word, you guys have probably heard it, called multidisciplinary or comprehensive or integrative medicine. And what that means is that we need to put a little bit of everything from the kitchen sink towards chronic pain to get it better. It means we need some Vicodin sometimes, and some Tramadol and some Oxycontin. And sometimes we need some ibuprofen. Now, I know in hemophilia, you can't always take ibuprofen, so that's not always a category for the group of patients that might be listening or participants today, that you can take that. But sometimes you need a little gabapentin and a little bit of neuropathic agents like the lidocaines and the bupivacaines. And sometimes you need the ketamines and the clonidines and things that are in the NMDA receptor antagonist categories, although clonidine is really alpha 2, but we'll throw it in with ketamine for today's purpose. And sometimes you need a block when you go to the OR, when you're having that knee replaced. You might need to have a nerve block as part of your general anesthetic. And sometimes, because your mood's getting down, because you couldn't go to the mall and you couldn't walk around with your family and your cousins, you need an antidepressant. And that's okay, because we know if we elevate your mood with that antidepressant, that at least the mood part of the whole pain syndrome is better. So we can modulate things by taking care of all the different little symptoms. And it's really important now that we don't forget things like psychology, massage, rolfing, acupuncture, physical therapy, occupational therapy. Those are our non-pharmacological treatments that really have been proven in literature to make a world of difference. They are complementary to the medications, even like the medications are complementary to them. And we also know in very well studied and documented literature sessions that medications from different classes will work better than all of one thing. So instead of taking 10 Vicodin a day, it might be better to take 5 Vicodin a day and 5 gabapentin, or 2 gabapentin, 6 Vicodin, and 2 nonsteroidal therapy agents. So mixing your medications will have a better effect than all of one medication. And we also know that we've diverged even more and more and more into more medications we put into that mix. So we used to say, well, Tylenol. Why are people always giving people with pain Tylenol? Tylenol doesn't do a lot for pain. True. That's a true statement. It doesn't do a lot for pain. But do you know what Tylenol does? It makes pain medications work better. And that's why we like Tylenol. Tylenol will take that ibuprofen and make it a little bit stronger. Tylenol will take that Vicodin and make it a little stronger. Tylenol will take that lidocaine block that you're having for your knee surgery and make it a little stronger. And we call this all together multimodal analgesia. And it is now the standard of care. So everyone should be getting a mixture of medications, unless they are by chance doing great on one thing. And everyone should get a mixture of different type of techniques, rolfing, acupuncture, anything that works for you should be okay. Memantine is a new medication we introduced with gabapentin and pregabalin. We introduced dexmedetomidine now, that's an alpha-2 like clonidine. We have lots and lots of IV medications we can use in the hospital. We do epidurals now safely in lots of people for surgery. They're not just for people having babies. We do intrathecal and spinals. We do a lot of peripheral nerve blocks with catheters that can go home after surgery. A lot of things we can do to make the pharmacologics work better. Now, what are the numbers? People ask me all the time, if I'm taking pain medicines, is that okay? Is it okay to be on Vicodin? Is it okay to be on OxyContin? Is it okay to be on oxycodone? And the answer is, yeah, it's totally okay. You just want to try to keep your numbers lower. And the reason we try to keep the numbers lower is really not out of efficacy. There are some efficacy studies that say that at 50 morphine equivalents, you won't get as tolerant to your meds, so they quit working. You won't have as many side effects like constipation and nausea and sleepiness, which opioid medications are classic for causing, but you will also be safer. That's the main reason all of this came out. These studies came out of safety studies. And when the CDC made their opioid guidelines in 2016, it was based off of safety. It was based off the fact that at more than 300 morphine equivalents per day, people were getting too sleepy on their medications or having accidental overdose events. And when I say morphine equivalents, that means adding up all of your pain medicines you're taking in one day, and the total milligrams shouldn't be more than 300. So that's adding your short-acting and your long-acting opioid medications and having not more than 300 milligrams in a day. And when the CDC came out with their guidelines, we were trying to stay at 150 morphine equivalents per day. We dropped it to 90 not too long after that, and now we're sitting at about 50. Do I think it will go lower? I don't think it will. I think it's going to stay at 50. 50 is low enough to be really safe and to still work, because now there are some studies coming out that talk about what we call ceiling effect. And ceiling effect means that yes, your opioid pain medicines will work for you, Vicodin, oxycodone, OxyContin, but if you get too high, maybe somewhere above that 50 or 90 morphine equivalents, you will get more quickly tolerant and they won't work as well. There is an optimal number at which those medications work the best. Now, new opioid that we're using for chronic pain, not new opioid, but new for chronic pain, is buprenorphine. You probably all have heard of buprenorphine. It comes in many different tones, many different names, depending on the brand. You've probably heard it as Suboxone, as Subutex. Belbuca is another name people hear. But buprenorphine is a really, really old medication. It actually came out in 1966, believe it or not, although we weren't really using it then. And it really became popular in the United Kingdom, in England, in 1978. And they started using it IV, and they found that this is a much safer, good medication. And in 1981, our own FDA here in the United States approved it as an injectable or IV buprenorphine, and we called it Buprenex. I don't know if many of you remember Buprenorphine, but it was a Schedule II opioid medication. It was here, but no one really used it. And then in 2002, it really started gaining some steam in the United States. And we came out with sublingual buprenorphine and naloxone mixed together called Suboxone, and sublingual buprenorphine called Subutex. And we scheduled them as Schedule III opioids. And the classifications of the opioids and all controlled substance medications get classified by the Federal Drug Administration is dependent on how dependent and habit forming they can be and how safe they are. So the higher you are in a number, 3, 4, 5, the scale goes to 5, the safer your medicine is, and the lower you go, the more dangerous it is. 2 is the most dangerous or habit forming and sedating agents, and 1 are what we consider illegal or illicit substances. So 1 is heroin, is actually marijuana, because even though marijuana is approved by many states for medicinal use and recreational use for pain and for other entities, it's still considered illegal by the federal government, even though pretty soon I think they'll turn that around. So buprenorphine has come out now as a treatment, not just for what we call medication-assisted treatment, which is for people who want to get off of their opioid medications or we're having problems with illicit substances or street drugs, but for chronic pain management as a true just round-the-clock medication. In 2010, it became so popular that the FDA approved a patch called Butrans, and it's a transdermal system patch. And it's for severe pain that requires daily treatment. And in 2015, we also came out with another form of buprenorphine for around-the-clock pain called Belbuca. And this is a buccal or buccal, however you want to say it. Most people say buccal, some say buccal. Buccal film that you stick kind of in the side of your cheek or under your tongue. Pretty similar to a sublingual tablet. So we now use buprenorphine just for pain management. You don't have to be in trouble on your pain meds or have been in trouble with illicit substances or know someone who's in trouble or have accidentally taken too much to get on buprenorphine. We prescribe buprenorphine as a mainstay pain management item. And it's shown now in studies to be better probably than hydrocodone and OxyContin and oxycodone. Now, a couple things about buprenorphine that make it special. Number 1, Suboxone and Subutex are probably the most famous and they're the most used. Suboxone has naloxone mixed in it. And this is the drug you hear of that if someone tries to crush or chew up or smash up their Suboxone, instead of just swallowing it whole, they can get really sick because that naloxone is an opioid blocker or a receptor blocker, and it will put you in withdrawal if you're already on opiates and you take your Suboxone. Buprenorphine Subutex is just pure buprenorphine. It doesn't have that naloxone component, so you won't get sick if you crush it up or chew it. And these medicines are mostly used for office-based treatment of what we like to call opiate dependence, or people who feel like they've become too dependent on their opiates and they want to come down on their opiate medication or get off of their opiate medications. And I put this second line to say they're now standard of care for chronic pain as off-label use. And it's really not even off-label use because as you saw from my previous slide, Belbuca and Butrans patches aren't even off-label use anymore. They are indicated for chronic pain management. And your physicians and your nurse practitioners and your advanced practice providers, your physician assistants, do all still need special licenses if they're giving these medications for an opioid use disorder, or use disorder, meaning someone who feels like they're too dependent on their pain medicines, but anyone can write it for pain. And so we're really starting to use this medicine a lot more for pain. It binds really, really highly and with really strong affinity to a couple of our opioid receptors, our mu and our kappa. And we like that because that really tight binding keeps other medicines from getting on board. And that's a good thing because it means that buprenorphine holds on so tightly that it really, really works for your pain because it doesn't let anything bump it off and it stays on there and it works. It's hard though, if you're on buprenorphine and you go into the hospital and your anesthesiologist needs to put you to sleep and they need that buprenorphine to fall off those mu receptors so they can get the anesthetic opioids on board. So there are some special things we do for people if they come into the hospital and they're on buprenorphine. And one of the special things is we can't do traditional opiates. So if you come into the hospital on buprenorphine, we have to have a little bit of a game plan, because we can't just give you the standard anesthetic and have it work, because that buprenorphine is really hanging on to those receptors that we as anesthesiologists need free to be able to give you your anesthetic. And I will say that we do have to be careful too, because while you're safer on buprenorphine as an outpatient than other meds, when you come to the hospital, if we don't do it right, we can make you at a little bit more risk for being too sleepy or having breathing problems. If we've still got your buprenorphine hanging on, because it hangs on for about 7 days from the last dose you've taken, and we're putting new medicines on at high doses to try to push that buprenorphine off your receptors. But these are things the hospitals know how to do, and pain physicians know how to do, and most of your hematologists probably know how to do. But it's just some things to keep in mind about some of these newer therapies, like getting you on buprenorphine as they start to abound in the general public. Now, a couple of things you can do if we put you on these new buprenorphine projects is you can consider stopping your buprenorphine before you go into a hospital or have a knee replacement or ankle fusion or an ankle replacement. But we don't really do that as much, because we found these meds are hard to go on to and hard to get off to. While they're smoother sailing when you're on buprenorphine than, say, Vicodin or oxycodone, it's a little bit harder to start and stop buprenorphine than it is oxycodone or Vicodin. So a couple of things that we do is we may lower your dose a little bit before you go into the hospital for a bleed or before you go into the hospital for surgery. And we may add some other types of medications, other types of opioid blockers to your buprenorphine. You may hear people getting this. And we're going to use really fancy guns like the ketamine and the clonidines and the dexmedetomidines and some of those things I talked about on other slides to make your buprenorphine work better while you're in the hospital. And we'll probably give you a block, because if we give you a block, you'll have some pain relief from your block and you won't need as much of some of the other medications. Now, low-dose naltrexone. This is another little guy that's popped out in the world that's kind of new. And low-dose naltrexone has been around since 1984, a really, really long-term drug. And it's an opioid blocker. It's a pure blocker. So it's a little bit different than your opioid antagonist. So it's different than your other opioid antagonists in that it fully blocks. It's not partially blocking your receptor like buprenorphine, but fully blocks, but it only blocks for a little bit of time and it doesn't hold on that tight. And in the olden days, we used it for misuse and alcohol use, and we used it like at 50 to 300 milligrams per day. But now what we do is we use it at really low doses, and this is called low dose naltrexone. You may have heard this as LDN. We use it at really low doses, and so it just blocks a tiny bit of your mu. And people say, well, why would you want to do that? Don't you want to block a lot of mu if I'm really hurting? Well, yeah, you would, but there's a couple advantages that we're going to talk about in the next slide. You block a little bit of your mu and you don't have a lot of side effects. And what does that do when you block a little bit of your mu? When you block a tiny bit of your mu, you can affect the immune system and the inflammatory system. And people say, well, why do you want to affect that? I'm already hurting. The last thing you want to do is affect my immune system. Well, we now think the chronic pain is this chronic, overwhelming inflammatory response. And so our goal in chronic pain is to lower down this abnormal inflammatory response and this abnormal immune response so your pain gets better. And low-dose naltrexone can do that. It can only do that in low doses. So this paradoxical effect of improving this abnormal immune system doesn't happen at the high doses like 50 milligrams. It only happens in the low doses. And it happens because at low doses, here's your whole punchline, and the secret is that this low dose blocking with this low dose naltrexone increases. It gives you what we call an adaptive increase in your natural feel-good hormones, in your natural endorphins, and your natural enkephalins. And this increase in your natural endorphins kind of normalizes this abnormal immune response to help with pain. And it does it by balancing what's called your mu and delta. And your mu and delta are kind of opioid receptors that low dose naltrexone binds to, and it binds to in a balancing act. And when you balance mu and delta and block 2 of each instead of 6 of delta and 4 of mu, or 6 of mu and 4 of delta, when you balance mu and delta, your immune system is much more balanced. and you can kind of affect the abnormal inflammation and immune that's going on with chronic pain. And how it does that is it only blocks mu. And by only blocking a little bit of mu, it makes your body even with delta, which is already sitting without you taking anything in a little bit of blocking. And the other thing low-dose naltrexone can do, not proven in humans, so this is theoretical, and this is why I'll put question marks behind it, is we think it prevents glial cells from activating. And glial cells are these cells that live in your microglia and cause inflammation. So if you prevent this abnormal response by blocking these cells that cause inflammation, these glial cells, and by balancing these mu and delta, you might be able to affect the pain response. And I like to think of mu and delta as a teeter-totter, with delta having 1 rock on its receptor and mu living at 4 rocks, 5 rocks when you're taking Vicodin. And low-dose naltrexone is a slight mu blocking. It's not 4 rocks, it's maybe 1 rock. So imagine if mu is 1 rock and delta is 1 rock, that teeter-totter is totally aligned and balanced. And if that teeter-totter is perfectly balanced, that abnormal immune response starts to come back into balance and help our chronic pain. Now I'm going to kind of end today because we have about 9 minutes left until we get to our question and answer with a little bit about some of the marijuana products. And I could do a whole talk probably just about marijuana, but we're going to just do a little bit today. So the marijuana products are kind of special, and they're special because they're kind of in the category right now of botanicals. And botanicals are really hard to get approved through the United States and through the FDA because they haven't had a lot of statistical significance behind them. They're kind of treated as herbals. They're kind of treated like a plant because remember, marijuana and hemp are both plants. And so when you have these plants, there's not a lot of data already out there to really give them a lot of gumption behind them to go up for these huge multi-center, large, multi-randomized clinical controlled trials that the academic centers like. So we work really hard to try to get these studies in big trials so that we then can get them approved as prescriptions. But they work best when they're single element drugs, when they're really simple plants or herbals that are one thing. Well, as you know, marijuana and hemp aren't one thing because marijuana is this plant and every marijuana is grown different and has all these different mixtures of CBD and THC and CBD and THC and all these different chemicals and different derivatives inside this marijuana plant that make it really hard to make it be a single element or a single extract. But that being said, we have had 4 CBD products approved for prescription use for seizures or epilepsy in children. We like to say refractory epilepsy or refractory seizures, meaning epilepsy in children. And that's Nabilone in 1985, Dronabinol in 1992, liquid dronabinol in 2017, and Epidiolex in 2018. So these medications came about, and these are CBDs that are used for seizures in children. But what we're finding for pain is that you have these natural endocannabinoid receptors. You have these natural receptors that lie in your body, and we call them the endogenous cannabinoids, and they're CB1 and CB2 is what we call them, and they live in different spots in your body. And CB1 receptors are found on your neurons, on your musculoskeletal junctions, and they kind of work to inhibit neurotransmitter release. So when something binds THC or CBD, this endocannabinoid receptor, you prevent things moving and you prevent neurotransmitter release for myofascial contraction and musculoskeletal contraction. And that's great. But in the pain world, we found that we really, really like the CB2 receptors because the CB2 receptors lie on your immune cells and they lie on these things called microglia. Remember that word, glial cells? And what did we just talk about with chronic pain? That it's a chronic inflammatory response and it's an immune-mediated response. So if we can bind these CB2 receptors and affect the abnormal immune response and the abnormal inflammation of chronic pain, we're on to something with fixing pain. And we now know that CBD can bind these CB2 receptors. Now, when it binds these CB2 receptors, it really works as what we call a CB2 agonist, and it tends to really have a significant effect in targeting pain and working on anti-inflammation. And anti-inflammation is the whole goal we're getting at. So what I think you're going to possibly see coming down, and what the FDA and the federal government is working on now, as well as many large research centers, is they're looking at a possible indication for a CB2 prescription medication to have a really good indication for chronic arthritic and musculoskeletal pain. And why do I bring that up in a hemophilia meeting? Because what kind of pain do we see often if you have hemophilia? We see an arthritic and musculoskeletal type pain. We see a lot of joint pain, osteoarthritis of the ankle, osteoarthritis of the shoulder, osteoarthritis of the elbow, because of bleeds into that joint or into those joints that causes a destructive type of osteoarthritis over time because of the bleeding. So this might be a really big potential coming your way if we can get some of these CB2 receptors out and about, and we can block them with some of these CBD components that might be able to be medically manufactured, so you know a little bit more about what you're getting, and maybe even a little stronger and purer than what you can get now in a dispensary. And at the end of the day, what we're really still looking for is we're trying to find some type of rapid onset pain reliever for hemophilia, because we know you get bleeds and we know you're limited on options, right? A lot of people with hemophilia are limited because you can't take things that cause you to bleed more, that have platelet effects, like sometimes the antidepressants and like ibuprofen and Aleve and Mobic and naproxen and Celebrex. Although the Mobics and Celebrexes tend to be a little safer and often okay in hemophilia because they have less bleeding effect. Not a lot of new things are coming in chronic pain that are rapid onset pain relievers, but I don't want to sound too much like a negative person here, because we are working on things and things will hopefully be coming, but we are looking for things that are rapid onset. So when you have that bleed, we can just give you that CB2 receptor body protein product and it'll come fast, or give you that CBD, or give you that low dose naltrexone, or give you some buprenorphine that will work quickly and help in the acute bleeding situation, but also have a potentiality to work for chronic pain. And we do want to minimize opiates, not because we think you're going to take them incorrectly, or not because something bad will happen for you, but because the studies say they work a little bit, but there probably is something better.
And I'll go ahead and just state the first question here.
Okay.
For those who may not know, can you share a little bit about your experience working with pain management in the blood disorder community, please?
Yes, I can. So I'm in our pain management department at Oregon Health and Science University, and we have a large hemophilia treatment center here at OHSU for Portland and the greater area. And they asked me to come and work in their hemophilia treatment center. So I have the privilege and honor of working right in the hemophilia treatment center with all of our patients, together with our hematologists and our physical therapists and our occupational therapists and our social workers and nurses and counselors and the whole team, the medical assistants. And because of that, then I got involved a little bit with NHF and HFA. And so I've been able to be introduced and meet a lot of people around the country and do a lot of talks and being involved with the community. It's been really an honor and a pleasure, and it's been a lot of fun. But that's kind of my background. It just came out of working in the clinic, and I still work there. We've been doing a lot of virtual work, but we're starting to open up a little more now in Oregon, so we can have people come in a little more live fashion.
Thank you so much. And we did have a question that came in. I've been routinely taking. Do you see the question there, Dr. Mallow?
I do.
Okay.
I do. You want me to read them? So the question is, routinely taking tramadol for some time, but is tending to cause disorientation and nausea when used for my bleeds. Is there something else that wouldn't cause such side effects, and my hemophilia treatment center will be familiar with it without having too much concern? And there is a lot of stuff you can do that's similar. Tramadol is really, really great. The thing I love about tramadol is it does have an anti-inflammatory property. It is our closest pain medication as far as an opioid medication to having anti-inflammatory properties, but it can cause disorientation and nausea. So a couple of things that I would say would be something like maybe Celebrex or meloxicam, which is known as Mobic, would be something that you could do. And then you might be able to even go to something a little more serotonin than tramadol, but with a little bit less of the nausea and disorientation, something like a Savella or a Cymbalta. And I'd be happy to talk to you more about that later. But that would be one thing that might be helpful. What brand of CBD is a trusted supplier? That was another question in our chat. There is no great trusted supplier yet, as far as I'm aware. CBD is going to be very varied no matter where you get it, what dispensary, what purchaser, what online supply company, because none of it is federally regulated. Not meaning that when it's federally regulated, it's better. It just means that once it's federally regulated, we know more what's in it, and we can kind of start to study better suppliers and better constituents of the CBD. So really right now, while what you get is good product, they're all very varied depending on the plant that's growing and depending on if it's marijuana or hemp, and depending on how it's mixed and grown and extracted from those plants. CBD oil is promoted for a variety of ailments. How is it for pain management? Is it allowed where medical marijuana hasn't been approved? Great question from Cheryl here. CBD oil is good for medical management of pain. I will tell you that anything that's in an oil base, CBD is what we call lipophilic. It does need to be in something fatty like oil or sugar or something what we call lipophilic, because otherwise it doesn't absorb. So I'm glad you're taking it in an oil. But because it's not regulated too well, we don't always know how much CBD you're getting. And so we don't know without knowing the amount you're getting, how well it works. We don't have great studies on CBD, but our early studies say that you need a lot of it to really work. So depending on how strong your CBD oil is, you may or may not get great pain management from it. And is it allowed where medical marijuana hasn't been approved? Ooh, that is $1 million question. So technically, CBD is still considered part of marijuana because it's part of the plant, but it's not the part that people don't like as much, which is the THC. So that's going to depend on your individual state guidelines and your board in your state and your individual guidelines from your personal practitioner. Some people allow CBD even if there's not medical marijuana, and some people don't. And it all depends too also on your state board. I've had an effect of some joint pain reduction after a few years on Hemlibra and more control of a couple of target joints. I like that. Yes, Hemlibra, I am not a hematologist, so I don't know as much about it as a lot of other people do, or as much as you guys do, but people have said they've done really, really well on Hemlibra, and I know it's done a lot for a lot of people's pain. I think it's great stuff personally. And then it says in here, great questions. I agree, these are fabulous questions. Does Tylenol increase cannabis effectiveness? It does, believe it or not. We don't have very many studies on this. Most of the studies about cannabis and Tylenol are what we call deduced studies or deduced deduction, because it does so with everything else so far. So yes, we think it does, but there's no great randomized big trials on that. Arthritic ankle pain is my main problem these days. What is the timeline on release of the CB2 medications? Great question. I do not know. I do know two things. They're working on it really fast. I do know COVID has shut down everything to go slower. I do think it will be coming, although I haven't heard specifically there's something coming with a date, but I do know it is a goal to get some medications out. At what point of severity of chronic pain does it become appropriate to consider buprenorphine? That's a really great question. And what I would say as a pain provider, and this is my feedback, nothing, like hardcore evidence here, is when you feel like it's time, when you're to the point, Mark, that you feel like, it is really, I'm not getting anywhere and my life is too impacted and I'm ready to try something new, that's when I would say you should go for it. I don't think there's any rule out there that you have to start at a certain point. I think when you feel ready is the right time.
We do have a couple of minutes left. If anybody else wants to type in a question, feel free to do so. I also will have my email address listed here if you have any additional questions you want answered that didn't get covered.
Yes, and I'm happy to get back to anyone as, whenever I can, if you have any other stuff for me too.
Seeing any more at this time, we do appreciate you, Dr. Maurer, for sharing your nuggets of truth with us.
Well, thank you. Thank you guys for having me. I'm always very pleased to be asked and consider it an honor. So thanks for spending time with me today.
Sure. And I do want to go ahead and make sure everyone is aware of our evaluations that are available. We do encourage everyone to fill those. And when you fill it out, just as a reminder, you'll get that in your email tomorrow. You have until Sunday, the 29th, to be entered into a raffle as well once you complete those. We do thank you all for attending. We thank you, Dr. Maurer. We thank you for the help on the backside with our NHS staff as well. Have a good night, everyone.